Happy
Happy
Mother's
Sunday.
Day and happy Mother's Day.
Happy Mother's Day to all the wonderful mothers out there. Hopefully everybody had some well-deserved rest and relaxation this weekend, and especially today.
We were thinking about on Mother's Day, knowing that a lot of people are going to be with their family, hopefully, or even that they, to be able to do something that means a lot to them. Hopefully, everybody was able to do that. I know I can speak for myself. I certainly did. I was able to be with the kids and Joe and actually see my dad today, too. So it was really nice to still be home, did a few house projects, and it was just overall really nice day.
Yeah, great day, and I think great weekend overall. Unseasonably cold for May, but still made the best of it. Yeah, the kids and I were able to put together a Sunday Mother's Day breakfast, and we even ate it outside. Cora had her winter hat and gloves on, but we still did it. So yeah, awesome weekend overall.
I just wanted to circle back a little bit about last week's episode. It was so awesome. We immediately got off thinking we could have talked for an extra, hour really on some of the questions that we had. And we're still new to this to see like really how long or short is able for people to sort of fit it into their day with some of the content. So it was, thank you again to Tiffany and Mike who really just shared all of their knowledge or some of it and really could help a lot of us out with the nutritional concepts that they shared.
Yeah, they did an awesome job, and I've had a lot of great conversations even this week. People in the clinic, a couple people reaching out by email, and so yeah, we wanted to thank Tiffany and Mike again for coming on. Awesome information and super useful. So if anybody missed that, please go back. It'll be on our YouTube page, our Facebook page, and even though it's a longer video, it's packed with great content and some really useful information. So.
I wanted to share before we get into the pain that we at Choice, so every month, and I'm sure everybody who knows, we're constantly looking at a local organization. This month is Mental Health Awareness Month. And at Choice, we are taking on a 31-day self-care challenge. It was something that a lot of our team members brought up, that mental health either affects someone they know, maybe it's affected themselves in the past, or a family member. And the National Alliance on Mental Illness has a local New York State chapter, and they also have a really cool self-care challenge where it just gives you time to sort of take a step back and look at a date. I'm going to post a link to the PDF of what we're doing at Choice, and it's just really simple. We've shared it to some of our patients. For our own team, we're creating a challenge where we're having, if you do it, to write it in our team Facebook page. So I'll share that link down. If there's something that definitely on Mother's Day, and other days as well, I think we need to be taking care of ourselves. So hopefully that this link and this PDF to some ways that you can is helpful for everybody. So I'm going to post that in the links while we get started here. And also, one thing you might notice in our title here tonight, Joe and I are wearing our doctorate of PT hats. We've been patients for some of the anxiety and stress. We've been sort of learnees for the cooking, but tonight we wanted to give back and sort of talk about what we do every day, day in and day out, about the pain. So we normally go by Joe and Aaron, but tonight as PTs and delivering you this awesome content, that's why you might see that there.
Joe and Aaron still works too.
Yeah. Right. I know. I'm not going to be calling you Doc right now, Joe.
Yeah. No, never. Yeah.
All right. So let's get right started.
Yeah. So no pain, no gain is a common term, a common phrase, I guess, that we hear all the time. And we hear it during rehab exercises. We hear it as people are going through, whether it's an overuse injury or a kind of a post-surgical recovery. And I think it's just been kind of beat in our heads growing up. Like, you have to have pain in order for there to be a gain. Like, if I'm not feeling pain, there's probably not going to be positive changes that are happening. And I became aware of this phrase, stolen from somebody else, but I loved it. So no pain, no gain. So KNOW, pain, KNOW, gain. If you know pain, if you have a good relationship with pain and then an understanding of what it means, why you might be experiencing it, then you have a chance to really make some gains and smart gain. So it falls a lot into work smarter, not harder. So no pain, no gain. When we're talking about pain, there's a lot of different maybe misconceptions about pain. There's a lot of different assumptions about pain. And it's not necessarily, pain isn't necessarily a bad thing. Again, if it's taken into context, if we start to ask ourselves some of those questions, and if we follow some seemingly simple rules, and try to, early on episode 1, we talked about expanding our circle of influence as opposed to our circle of concern. What happens is we feel pain, and then all of a sudden that's concerning. I can't do something because there's pain. I can't get out and do that workout. I can't lift up my grandchild. I can't make dinner. And what happens is that concern starts to consume us. We start to compensate. And what we hope that people get out of tonight, some of the strategies we share, some of the things that we're able to talk about, is how do we help you expand that circle of influence and maybe change some things up, listen to what the pain is telling you, and start to really strategize around it. So that's no pain, no gain. I think, as we transition, as we talk, Erin and I were in the same PT class. In a lot of ways, she helped me through my PT classes. She was my my tutor. And when I think back to PT school, if any of my professors are listening, apologies. But when I came out, in my mind, thought, this is orthopedics and this is what we do. This is neurology and this is what we do here. This is pediatrics. This is geriatrics, so on and so forth. All the different subsets of medicine and physical therapy were almost separate and distinct in my mind. And really what we're starting to learn, what there's a ton of information coming out recently, is the brain and the nervous system are always on and really play such an integral part in how the body moves overall and can affect so much of this, that it's really important to almost look at it as human movement applied to different populations. So it's what we did in neurology, what we learned as physical therapy students in neurology, is very applicable to our patients in orthopedics, recovering from rotator cuff surgery, recovering from neck pain, overuse, low back pain. It's just that it might be affecting them differently, but the neurology is the same, and it still plays a large role both in how we experience pain, when we experience pain, and we can start to implement some of those strategies as to how we can move forward, how we can accomplish some of those goals that we lay forth. So what we're going to do is kind of talk through, so we talked through the roles of the nervous system, the effects on everything else. The last part to really understand before we kind of go into the next section is that nervous system affects so many things. So a lot of people can come in and they feel hip pain, lower back pain. And when we're going through our assessment, it's important to understand that the nervous system plays multiple roles, in that it's like the electrical circuitry through our body. So starting up at our brain, that being the control center, there's a central nervous system, which is our brain stem, our spinal cord, and then there's the peripheral nervous system, which kind of expands out down our arms, down our legs. Those nerves are sending signals back and forth to those muscles, to the tissues, our skin, the joints, and all of those structures are innervated and getting signals. And we need the nervous system to be healthy in order to be able to move forward. So I think so many times we think, oh, I must strengthen something if it's weak. I must stretch something if it's tight. I can't tell you the number of people that sit up on the exam table, they have lower back pain, and they look at me like I'm crazy because I go and test the strength of their big toe. It's weak, and I'm trying to explain to them, hey, the L5 nerve root, one of the most commonly irritated nerve roots in our lower back, sends the signals to the muscle that controls the big toe and our ability to hold the big toe up. So for us as physical therapists, as professionals, that's one of the first things we want to test and see how that circuitry is working. If someone has lower back pain, are all the signals getting down there? And then 90% of the time, we'll do interventions, we'll do treatments up at the lower back, We do nothing to strengthen the big toe. We'll go back 10, 15 minutes after treatment and test, and that big toe is stronger than it was, 10 minutes prior. That is just a product of the nervous system having stress taken off of it, the nerves signals being able to be sent more efficiently. And that's really where we can start to make progress. If we look at it for the whole picture, that's where we can start to really move forward.
Joe, I know one thing that I thought stuck out was when you were like, pain is not always a bad thing. And it certainly it leads us to think that basically sometimes it's just telling us or telling our bodies that the tissue is being stressed to a level that it can't handle. And I know that without my patients, I'm constantly saying they'll tell me they'll gauge their activity that really their pain came on 10 minutes into their run or 45 minutes into their OTF class, and it's sort of a certain time that it comes on. And one thing I was wondering, or I thought we could talk about, at least about knowing pain and knowing gain, is the idea or the mindset behind when it's basically it's not just that the pain isn't there; it's when our brains are aware that it's happening.
Exactly. And we're going to get into kind of, how our body processes pain, where pain comes from. There's some maybe misconceptions onto why we experience pain, where the pain signals actually come from. But really, each of us have the chance to expand that circle of influence, like I talked about, and start to almost be detectives with it. And that's where the magic can happen. Because if you can start to say, well, geez, I had pain and it onset 45 minutes into my workout, but it wasn't there last workout. What did I do differently this workout? And then you can start to say, well, geez, now there's a common theme here. It's, each time I'm doing this exercise or each time I seem to do this exercise, coincidentally, I start to have pain after that. Now, what if the pain, it's like, geez, the exercises were the exact same. The onset was the exact same. Let's backtrack further. Let's go a layer deeper. What was different about going into the exercise today? Oh, shoot. Yeah. I had a work trip and I traveled out to Syracuse and back, and this was the only hour I had to get to the gym. And so, yeah, I did 6 hours of sitting, and then went into my workout. Okay. Now we can start to, if it's explainable, now we can be actionable. So many times we just take pain for pain and we don't take the time because we're busy to sit down and process and really think through, all right, so what were the variables? What can I change? And really start to be objective about it and try to put a plan in place to address it.
Yeah, that's great. And I wanted to mention, we did add an element to tonight's program where we wanted to be able to have a question and answer sort of section here with any pain you may be experiencing. So we will be asking of you. I know some have already mentioned that, but start trying to think of some of these questions that we'll be saying. So when do you feel the pain that you're having? During what activities does it come on most likely? What is the intensity of your pain? And what does it feel like? Is it sharp? Is it burning? Is it sore? Sometimes those descriptors will help Joe and I. So as you hear us talking about this, start thinking a little bit about the pain that you're feeling, because that'll better help us to sort of figure out what tissue it is and why it's being stressed.
So next I want to transition into the topic of structure versus function. So what does that mean? Classically in orthopedics, classically in the type of physical therapy that we do, outpatient orthopedics, we are very focused, and I think the assumption from the outside world is, we're fixing structure. So the best analogy here is your computer. So whether you have probably a desktop computer is the easiest to kind of break down. So hardware and software. So hardware is our monitor, our tower, the keyboard, the mouse. Those are the hardware. If you don't have hardware, you could have the most expensive software running. You need hardware to run. You also need software. So you could go out and spend a ton of money on the best hardware, but if you're running a software system from 1984, that hardware system isn't going to work as well. So it's important to appreciate both. In our body, the hardware are our bones, our muscles, our tendons, our ligaments, the cartilage, the nervous system, and those the integrity. So the actual physical structures, when I say the nervous system, the actual nerves. So that's the hardware. That has to be there. That has to be intact. What often gets overlooked and has for a long time, I think it's getting better now, is the software system. So the software system, when we break this down into common speak, is muscle memory, essentially. We talk a lot at our clinic about proprioception. That's your position sense. So it's your sixth sense, if you will. Everybody is very common with, or very comfortable with the 5 common senses: sight, smell, taste, hearing, and touch. Proprioception is your body's position sense. And so there are tiny receptors in your muscles and your joints, which constantly send feedback information to your brain. Over time, either because of recreational habits, occupational habits, maybe past injury history, that proprioception, those receptors can start to either send faulty signals, or you're not using all of those proprioceptors. And so the quote unquote normal for position sense gets distorted, and your brain is getting faulty input. So those are the people that if we're sitting there having a conversation with them and their feet are turned out like this, and then we tell them, hey, Aaron, your knees probably hurting you a little bit because your feet are turned out like this. Why don't you turn them straight? And then Aaron, for 35 years, has been used to this. So we turn her this way, and what does she feel? She feels like her toes are pointed in, because this has been her normal. Her brain has known this to be her normal for so long that just coming to neutral automatically starts to feel so foreign. And that's where we can start to make a difference, is improving that proprioception, starting to work on the brain's software system. So structure versus function, we talk a lot about, there's more and more research coming out about imaging findings. And so imaging findings are a huge part of medicine and a huge part of orthopedics. What studies are starting to look at is comparing the people that are symptomatic and the findings on their imaging with the people that are asymptomatic, don't have any symptoms, and the finding on their imaging. And what we're starting to find is there's more and more, it's more and more common, especially once we hit 30 years of age, we start to wrinkle on the outside, we wrinkle on the inside. The grays are coming in hot. That's my good side. The grays are coming in hot and heavy. And once we hit 30 years old, every decade of life, it increases more and more. We start to get degenerative changes. We start to get prone to disc injuries in our spine. We start to get meniscus irritation and some cumulative meniscus stuff in the knees, hip injury, degenerative hip injuries, rotator cuff stuff. So what happens is each decade of life, just like we gain more gray hairs, just like the wrinkles start to come a little bit more on the outside, the same process is happening on the inside. What we used to think, what we used to assume is, hey, if I image, like Joe's neck's been killing him, right? So if I image Joe's neck and I see arthritis, the arthritis must be causing his neck pain. Now, Joe thinks I have neck arthritis, and it's almost like a sentence. What we're learning is that if you image me, if my neck pain started 2 weeks ago and you did this imaging, this x-ray 4 weeks ago, likely the same amount of arthritis would have been there if there was no injury in between. So why is it symptomatic now? What changed 2 weeks later that now this same level of arthritis is starting to cause pain? We're starting to realize it might not be the arthritis completely by itself. Maybe that's contributing a little bit to the symptom presentation, but it's not just a hardware issue. There's a software issue to this. Geez, Joe's been doing a lot more telehealth the last 3 to 6 weeks. Joe's been crunched over his computer, not really focusing on his posture as much. Guess what's happening? Those proprioceptors in the neck are changing. The muscle tension in the muscles that run from the shoulder blade to the neck are changing, and that software system has switched. Now there's a little bit of cumulative inflammation around those tissues, and that starts to become symptomatic. So structure versus function, not just looking at what the structure is, but looking how the person is functioning, how the joint is functioning, and taking an appreciation for there's hardware, but there's also software, and we need to be addressing both in order to put together a full kind of comprehensive plan to move forward.
I think it's interesting, like, especially how you mentioned about the diagnostic imaging. I just talked with a patient on Saturday morning, and she is seeing an orthopedic, and she had her MRI report, and there was lists of things that were on there, lumbar levels 1, 2, 3, 4, 5, all the way down, and basically many of them were refuted to just normal degeneration. And as a 52, year old person, the surgeons, because that is what the diagnostic image is showing, and they have the norms over certain, several numbers of patients and what a spine looks like. So although we see the wrinkles and the grays on the inside, just to reiterate your point, some of that is normal wear and tear. And then you go and take your life's activities, whether you are an athlete, or you've had a major car accident, or you've fallen down the stairs, and that can just add a little bit more to that normal process. So I think I think that you hit the nail on the head about both things are changing, even just organically or naturally.
Yeah, and I think it's a big. I think it's becoming more commonplace, for healthcare providers to educate on this, and I think it's really important to do so because for so long, I mean, even if you look at the wording of some of these diagnoses that we see, even the imaging reports, if you maybe aren't aware of this, if a provider hasn't made you aware, if you aren't studying on this topic, you look at these imaging results and it's degenerative disc disease. Like, what? I have a disease in my neck, and that is just, that's just what was chosen to label arthritis, essentially. What was chosen to label the almost like normal dehydration that occurs in the neck. And so someone, even if we see like mild or age appropriate degenerative disc disease, it's
Right.
still like the terms degenerative disc disease, if you aren't aware, that almost, we talk about the nervous system all the time. We're talking about it tonight. The sympathetic nervous system, the fight or flight response, it's like, holy cow, maybe I shouldn't be moving my neck at all. And then we start to get the questions about, should I do a neck collar and these things. There certainly are appropriate times for, more drastic, more aggressive treatment measures. But I think as a community, as a medical community, we're getting better. And I would not be surprised if you start to see some changes in some of that wording. There's got to be other ones. So degenerative disc disease is always the example I use, just how it just sounds so drastic, even though it's age
Right,
appropriate.
mild narrowing or stenosis. So, I mean, I feel like narrowing is a descriptive term of this space between the joint or the nerve root pathway.
So another one is disc herniations, right? And disc herniations, we're learning those, certainly there are certain times and there are certain classic symptoms which we have to look out for and can become something that need to get addressed. You need to get evaluated by a surgeon. If those aren't there, what we're finding on these imaging reports, these MRI reports, it's being published that disc herniations can occur and they can be completely asymptomatic. I remember in doing my residency, we did a case study, and a pregnant woman, I forget why, she might not have been pregnant. So there was a woman in to see her doctor, and for some other reason, they did an MRI CT of her, like her abdominal region, and her lumbar spine was captured in it. And she had a slippage of one vertebrae over the other. And so in medical terms, it's a spondylolisthesis. What it's called isn't important. Essentially, the vertebrae sit on top of one another, and the top one was slid forward. That gets graded, usually on a percentage scale. So 0 to 25%, grade 1, grade 2 is 26 to 50, grade 3, 51 to 75. She was over 75%. The doctor came back in and said, who's addressing your lower back? And she had no pain. She had zero pain from it. So this was a case study we went through in our residency, and she still had to consult with a surgeon. She still had to go through the appropriate medical steps. But that goes to show, if someone can live their normal life like that, it starts to say structure versus function. We need to consider both. Luckily for her, she did get it imaged and taken care of. But it just goes to show one isn't always correlated completely with the other. Just because structure is shown to be abnormal or shown to not be pristine on imaging does not mean you have to have symptoms, does not always correlate with your symptoms. Moving on. Ready
Yeah,
to
so I was gonna say
explain
there are
pain?
a
Or you
couple
want
of
to do some questions? Yeah.
no, I didn't. Why don't we take Sue's? Why do our muscles tighten up so much? When I exercise, they loosen and feel good, but when my body rests, the muscles get so tight, and this seems like it happens over and over.
So that's there. It's probably multifaceted. That's an excellent question, Sue. So, uh, why do our muscles tighten up so much? One of the strategies we're going to talk about. So that's going to come up. So I'm not going to get right into that. Usually, it has to do with our nervous system, and it has to do with those muscles that tend to tighten up are probably overcompensating because other muscles aren't fully doing their job. So the best analogy I can give you is take two employees. So we'll go physical therapists at this point. Aaron and I both have a schedule full of patients that we're going to be seeing in a day. Aaron shows up, the diligent hard worker that she is, and she gets right to work. Joe shows up, and Joe's a little tired, so Joe goes in the back office and just falls asleep. Patients are still coming in. Aaron is now trying to see two therapists' schedules of patients, deliver great care, do all of the things. Aaron starts to get stressed out. Her shoulders are up here. She's breathing differently. Aaron probably just needs, right? She should just stretch out a little bit. Maybe Aaron should go grab some water. Maybe she should grab a coffee and like work harder, right? Aaron should just do. It's not Aaron's fault. Somebody got to go wake Joe up and tell Joe, hey, get out there. Aaron needs help. Aaron is overworked because she's doing the work of two people. You can take that same analogy into your body. So you always want to ask yourself, when the muscle is constantly, consistently tightening up, maybe it's not its fault. We can do the soft tissue work, we can do stretches, and sometimes that's appropriate, sometimes that's okay as part of the strategy. We've got to take it one step further and ask why. Why does this keep happening? Is it overcompensating for another muscle, which is supposed to be helping it out? Is it supposed to be, is maybe the antagonist muscle, so the muscle on the opposite side, is that overworking? We see a lot of stuff through the neck and the shoulder, and really what's happening is the muscle on the opposite side of the joint is pulling you into a different position. Now the muscle back here, which constantly starts tightening up, is in a cruddy position. It's not its fault. We could stretch this until the cows come home, but if we don't address some of the alignment issues and put this muscle in a better spot, put it in a place to be successful and efficient, we haven't truly addressed it. And we've gotten into this repetitive cycle of, man, I just got to keep this muscle loose. I got to keep this muscle loose. When you exercise, a lot of things happen. So endorphins kick in, and that has a positive effect, a powerful effect. So the endorphin hormone, and it helps to kind of, you talk about the runner's high, you talk about workouts, those types of things. So we feel better when we exercise. That plays into it a little bit. Body temperature, getting things warmed up, that plays into it. Depending on what type of exercises, you might be doing enough to kind of get that other muscle into the game to take a little bit of tension off of that overworked muscle for a bit. And that's probably why. But then the body rests, the muscle gets so tight, and this seems like it happens over and over. Sue, you nailed it. Like, this is a conversation we have over and over, and this is really what we're trying to get a little bit more to the root of tonight, and hopefully give some people some strategies. So we have some strategies coming up for you as to how to identify that, and then hopefully take some actionable steps.
Yeah, one thing she mentioned, it's typically her lower back, which feels tight, which I know what that whole antagonist and agonist theory is most likely going to apply here, that it's your lower back is working too hard for possibly the abdominals, the anterior structures, which may not be working as hard. They're the ones that are taking the nap.
Yeah, and it's, there's certainly a lot of things go into it. A lot of people at this time are sitting more. They're in positions that, I saw a comment from Marie where she's usually up and around the clinic and walking around the office more. Now she's in front of her computer more. There's a lot of positional changes. There's a lot of, everything kind of plays off one another. And so if we're assuming certain positions throughout the day, we almost have to find time to reset ourselves. Imagine if you never rotated your tires on your car. Imagine if you never changed the oil in your car. If you never rotate the tires, the same spot gets weared on over and over. We rotate our tires because it improves, we hopefully rotate our tires because it improves the longevity of the tires by distributing that load over time. So someone that's getting a lot of stress in their lower back, we look at things like the hip flexors, we look at things like the hamstrings, we look at some of these tissues which might be overworking, not allowing some of the core muscles, like Aaron said, to stabilize, and then you get into this faulty pattern. We're going to dive into this a little bit more when we talk about the super simple formula for injury prevention.
Awesome.
All right, ready to
Yeah, let's
jump in?
go.
You got any more questions there?
Guys, Joe has a list of things here. I wish I could show you, but we got a lot of things. The pain is one of our favorite topics, so let's keep going.
We're in our wheelhouse right now.
I
Yep.
know.
All right. Explain pain. In school, and a lot of times just in kind of life. So there's different, in school we're taught there's different theories for pain. There's different theories why you experience pain. There's been a lot of great research that has come out of, I'm pretty sure it's Australia. So David Butler and Lorimer Moseley, they have done a ton of really, really cool work. So their clinical book is called Explain Pain, and their kind of book for lay individuals or the general population is Painful Yarns. They're coming out with even more resources. They've been at it for about 10 plus years, but they do a great job at this. And essentially, there it is, Painful Yarns. Yep. He's hilarious in it. And basically that's a Painful Yarns is a super easy read. It's all just little stories about this guy's life. Quite funny. But he always relates it back to pain and goes from there. So
Well, Joe, why you said that, I want to let everybody know. Joe bought an extra copy of this. This is an extra copy that we have right now. As he mentioned, it is a super easy read. What we were saying is, or we want to sort of do a little giveaway. And if you just share this stream or this live feed right now, if you just go and hit share on your page or after we're done, we will, and then comment on there, no pain, no gain. We will pick a winner that we can give this book to. Where is it? It's not really on. Well, after this session. So go ahead and share this feed because we really appreciate it. And we will give this to one of you guys because it's a brand new copy. Sorry about that.
No, it's perfect. And so it's an awesome book. I was flipping back through it again earlier this weekend. And so he's got just great analogies. And analogies are so good because it just helps to break these very complex topics down into digestible pieces where we can understand it. So he leads the book off and he talks about kind of meeting this guy, and the guy's kind of like a wanderer. And so he gets in, this guy had just gotten this car, beautiful car, a little bit older, but he'd had it for about a year. And so Lorimer gets in the passenger seat, and the guy's driving. His name might be Ned. And he says, "Hey, if you need to talk to me or something, just tap me on the shoulder. You're not going to be able to hear too well." And the guy starts the car up and just cranks the radio, and it's not even music. It's like this like static sound. So they're driving, and he's like, what's with the static? Why are you doing that? And he's, when I got the car, it was like maybe a month later, and it's just started making this like ticking noise under the hood. And so I realized that once I started turning the radio up, I didn't hear the ticking anymore. So I just kept going. And then over time, he found he had to turn the radio up louder and louder because it wasn't just a tick. Now it was like a click. Now it was getting louder. It was progressing. So eventually he got it to the point where his radio just stopped working and it just started hissing at him. But he realized if he just kept that up loud enough, it was good. So Lorne was like, all right, that doesn't sound like the best idea, but all right. So they're driving along, and he hits this huge bump, and they're jolted around. He said, "Oh, if you need the next one, just sink your feet down, put your feet up on that box, take your arm and lock it under that bar, and you won't feel the bump nearly as much." So Lorimer says, "Okay, I'll does all the things." Next bump, yep, not nearly as much, but it seems like a lot to do. They take a turn, and he takes a turn a little bit too sharp. They pop a curb, drop down. the worst noise they've ever heard, and all of a sudden the engine just comes right through and is sitting in between them now in the front seat. It's still going, it dies out. They just kind of look at each other, and he's like, yeah, this has been going on for about a year. He's like, well, should we call anybody? He's like, nah. He said this guy was just kind of a wanderer guy. He's like, no, we'll just leave it here. Lorimer checks it out with the town, and it comes, and it appears there was no nuts and screws left. Anything, I'm not a car mechanic, I'm a physical therapist. Anything that was supposed to hold the engine in place, all those noises he kept hearing was just the engine starting to loosen up, loosen up, loosen up. There was nothing holding this engine, and then eventually it came right through. So the really the like the goal of the story here, the moral of the story, pain is normal, but it's a response. Basically, it's a protective device, and like ignore it at your own peril is kind of what he says. So if if you're feeling pain, your body is trying to communicate with you. And so you don't want to just crank up the radio. You don't want to just roll down the windows. You don't want to just jar yourself. Like, there's probably actionable steps to take. In real life, this looks a lot like the person that, maybe we're taking a leave. I was working with a patient, awesome person. This person, when they came in for their first physical therapy visit, when we're sitting down and talking and getting on the same page, he's like, yeah, I take 6 a leave a day.
That's
How long have
common.
you been taking 6 a leave a day? Probably the last 2 years. And so that, in real world terms, that is driving around with your radio cranked up. It is not to say that taking a leave is a bad thing. Taking a leave is not a bad thing. If your doctor prescribes it, your pharmacist, everybody's on the same page with it. However, if it's to the point where we're taking it to that level and we need it to get through our day, there may be other things that we could further explore, as opposed to just kind of altering it, and Lorimer Mosley's terms, kind of cranking the radio up and going.
So, do I have time for 1 minute to go over the talk about the hikers in the woods when they came out, or were you going to get to that?
You can go for it. It's another great analogy. It's, yeah, like a paraphrase of this. It's in there. It's in the book. Yeah.
So I just think this was so easy for you guys to all understand and also applicable to about knowing the pain and sort of being aware of it. It was a story about when there was hikers who were hiking through the woods, going all the way through, getting up to the top, seeing the mountain, the waterscape view, and having a great day, and then making their way down. And as soon as they get out, one of the hikers looks down and he actually sees that there's blood on his mid shin. And when he sees it, he immediately is like, ow, he hurt his leg. He cut his leg hours ago prior in the hike. But it wasn't until he actually saw the gash with the blood that his brain resonated to, I should have pain because of this. And that's why I feel like that's one of those. It fits with the theory about really knowing that it's what our nervous system, it's what our brain is detecting our body feeling. And if the one thing with the car and turning up the volume, if you're ignoring it too much, you can certainly put yourself in danger. But our body are feeling pain responses, and a lot of it is how our brain is actually detecting it. I just think that's so interesting because how many of us, maybe get stung by a bee or there's something happens prior and then we intensify it maybe because of the mood we're in or the day we're having. Maybe that neck pain that you have sort of constantly, if you're having a very bad day, the kids are being tough for you, kindergarten's hard, and that neck pain today is probably a 9, even though it's the same amount of pain that I had yesterday when I had cucumbers on my eyes and it was an easy day and that was a 2 then. So if that's helpful to sort of say, like, sort of understand our own perception of pain.
Yeah, it's all, it's a signal. So what we're learning is we kind of used to think, hey, I bumped my elbow, so a signal goes all the way up and then comes all the way back down to say that's painful. What we're starting to realize, what a lot of this research is telling us, is pain is an output from the brain. And so the pain signals are coming from the brain, not necessarily from the cut on the leg, not necessarily from the elbow that we just bumped. And so what we're starting to realize in it, our brain is great at storing information. And so every person's context is a little bit different. Every person's experience is a little bit different. And so if you've been in a situation where you bumped your elbow and then you found out later on, like, oh, you actually fractured your elbow when you fell and you bumped it, right? Now, every time you go to hit that elbow, you're going to jump and start, because your previous experience with bumping your elbow was it fractured. But 99.9% of the time that you bump your elbow, it's just a bump, right? You hit your funny bone, and it's better in a matter of minutes. Different people's personal experience can also play into this, and how heightened your sympathetic nervous system, your fight or flight nervous system is, definitely plays into it. So I've got another couple of things that kind of drive this home. And so, Aaron, let's pull up that screen share.
Sure. And Joe, let's bank. There's a couple of hip pain, whether it's anterior or posterior hip, that there are 2 to 3 people with a very similar symptom. So I've written it down. So we want to definitely make sure we sort of circle back to that.
Great.
All right, let me pull this up. I'm going to sneak out. If you need me, call me back.
All right. So what do we see here? This has nothing to do with physical therapy. So what you're looking at is, you want to see which line is longer, right? Is the bottom line longer? Is the top line longer? We've played these games a lot, right? A lot of people have played these games in our lives. Instinctively, if you look quick, the top one seems to be shorter. They're the exact same length. A lot of us, understand this and have done this. But that is kind of how our visual system works. That's how our brain works. I've got one more that kind of threw me completely off. So you'll see here the top box is labeled A and the bottom B. Which box is darker? Is the checkered box A darker, or is the checkered box B darker? I did not believe it. I was convinced that A was darker. They're actually the exact same color. So there's a guy. He's a neuroscientist at MIT, Ted Adelson. So if you do Adelson checkered box illusion, I think it is, A and B are the exact same shade of color. And so if you stare at it long enough, and what I had to do is kind of let my eyes go blurry and look at it, and then they started to look the exact same. Our visual system is so complex. And what happens is, our visual system basically isn't very good at being a physical light filter, right? It doesn't do light well. But that's not its main role. Like, its main role is to take the visual information it sees, break it down into its meaningful components, and then provide information into, like, put the objects in view. Like, our visual system is to view. Yes, we sense color, but that's not the main thing. Like, it needs to take all that visual information it sees, break it down quickly into its meaningful components, and then put it into objects that we can view. The pain response, the pain system in our brain is very similar. And so when pain comes out of our brain, when we have sensory input into us, whether that's we bump something, we've been sitting in a position for too long, whatever that might be, there are so many chemical processes that go along with the pain system, so much that has to happen so quickly. The main goal of the pain system is not, like, to detect physical damage. It's not to say, oh, you have pain because it's this level damaged. No, it's to break it down into its meaningful components, and it's to give you the information that you need for you to take action. Like, that's what pain is there for. So it's not to tell you that, oh, this tissue is, your shoulder tissue is this much damage, 50% damage, and that's why I'm sending you this signal. That's not the goal. The goal is break down the information that is being input to it based off how you're moving, based off whatever that hardware and software system is inputting, and then to let you know, hey, action needs to be taken, and it's your job then to take it. Or you can pop back if you want.
Yeah, I definitely got that question wrong. I was convinced the other one was darker.
It's crazy. And he gives a very in-depth analysis at MIT on MIT's site. But if you Google that, there's a ton of information. Yeah. Oh, Sue couldn't see. Hopefully people could see that.
It's because it was a little small. I can try to move it around. I don't really know how. I'll put the link. I'll put the link on
So
there.
basically, box B is like the first white box in front of the green object. So like diagonally to the left of that green cylinder.
It's in the shade.
And then box A is all the way up at the top right darkest box. Or really not the darkest box. Yes.
I'm glad I wasn't on the screen because I was like this.
I don't know. Could you kick both of us off? That's all right. So if you Google Adelson's checkered box illusion and then click on Google Images, it'll come right up. And then you can play the game yourself. Great party trick. Bet all your friends money and win money off of them.
All right.
Questions on that? Let's address the hip questions.
All right. Yeah. Okay, great. So both Linda and Carla similarly, right? Hip pain. Carla and Linda, if you could just tell me, is it anterior, so more like the front of your hip? Oh, I guess you can't really see. Or more in the back of your hip, like the buttock area. So I think you both mentioned it's the front of your hip, but let us know if that's where it is that you actually feel that pain. And similarly, it's after prolonged sitting postures.
So I'll start to kind of talk a little bit about the hip. And so the hip is a ball and socket joint. And so the ball is part of your femur, which is your thigh bone, and the socket is part of your pelvis. And the pelvis is a ring. It's made up of 3 bones. The pelvis has that socket on it. So the ball sits in the socket. Oh, perfect. One of each. That's good. That's fine. Yeah. And so what happens is the ball should be moving in the socket. With the hip, what we see a lot of times is a couple of different things. So the pelvis gets positioned differently. And so if you took the pelvis and you had tight hip flexors, and so now the pelvis gets pulled forward a little bit, that changes the alignment of the ball in the socket. Maybe one side of the pelvis gets positioned higher than the other. That changes the orientation of the ball in the socket. So when you add sitting to that, now you sometimes can accentuate some of these compensations, and depending on how long you're sitting for, that can cause irritation to those structures. We're hearing a lot of research now about femoroacetabular impingement. It's a fancy term for impingement, or like pinching in the front of the hip. There's a couple reasons. So there can be extra bone formation on the ball, which catches, or there's extra bone formation on the socket, which catches and essentially starts to irritate some of the tissue around the hip. The classic sign of that is kind of groin pain, popping, clicking, and so that's part of that. The other thing is, if it's a degenerative change type of thing where the cartilage of the hip is starting to break down, that's usually in the groin. That's not to say that nothing can be done besides surgery. There are a lot of things that can be done from a stretching standpoint, a strengthening standpoint, and that software system of getting all those muscles to work together. But what we usually start with is, what does the alignment of the pelvis look like? What does the range of motion look like at that ball and socket joint? Are things moving appropriately? And we put you in a kind of get you in a position where the structure is in a better spot. So now everything can start to function. So that software system can start to function more appropriately. So that's if it sounds like for Linda, so front of the hip pain, So those are some of the joint implications. The muscles there are the hip flexors, which as a society, just those hip flexors get super tight and overused. And that's because we just, as a society, do a lot of sitting. And so there's really good ways to stretch out the hip flexors. And we can certainly help you out if you have some questions on that. We can shoot you over some exercises there. If the hip pain is in the back of the hip, that can muddy the waters a little bit more. A lot of times that can actually be a compensation from either the SI joint region or the lower back. There's a lot of muscles which attach between the SI joint region and the lower back, and then out into your hip. So if the pain is kind of in like your back pocket area, the back of your hip region, that usually is a sign where we still look at how the mechanics of the hip are. We still try to see how the rotation is. We still essentially look at the pelvic positioning. But that makes us tend to think it might actually be kind of a lower back issue. There are clinical things that we can do, like testing the strength in your lower legs to see if a nerve is compensating at all, certainly going through the hip range of motion things. If both are having trouble with sitting, the easiest fix is going to be take your position when you're sitting and ensure that your hips are positioned higher than your knees, depending on how tall you are. And we do have a video. Maybe we can share the PDF on here in the comments or something, Eric. Yeah, yep. So most people get the recommendation, if I'm going to sit for long, I need to put a pillow behind my back to support my back. For most people, you should actually put the pillow on the chair and then sit on it so that your hips are positioned up and your thighs are angled downward. What that's doing is it's putting the hip in a better position. It's not crunching it up so much and kind of tightening everything down, because then when we go to stand afterwards, that's where things don't want to stretch out, and that's where it's, holy cow, it takes me a couple steps to get going. If you can get the hips positioned higher than the knees, the transition from sitting to standing will be day and night better. And then you'll start to, you won't get that cumulative stress over time.
And so this also, Marie, you were asking about same thing, how to prevent sciatica with working from home and doing more telehealth. This is the same thing. And some of the worst seats for our bodies are the couches, the recliners of the world. I really think furniture manufacturers, they design furniture for 6 foot tall men. And when you take petite, that's what I'm convinced. I've got no data on that. But when you take somebody who is maybe the average woman height, 5'5" or shorter, and we're trying to make up the distance of where our thighs meet the back of either a chair, a comfortable couch, a recliner, there's no way we can physically do that because of our own body types. And they have to make the furniture big enough for larger body types. So then we get into that position where our hips are much lower than, I'm always in the bad angle. Our hips are lower than our thighs. So here's our back. Here we go. And our hips are sort of sunk in and stuck. That's going to really tighten and restrict your hip flexors, those anterior hip muscles, and put our backs in a position where it's more vulnerable to some of that short-term bulging. So I think that what Joe's talking about is trying to get our hips above our knees and trying to really avoid those super comfortable, larger couch positions or seats.
The other big take home for men and especially women is watch the position so your feet should be flat on the floor if at all possible, because it's going to take a lot of stress off of your spine, your pelvis. But once your feet are flat, don't allow your knees to cave in. So don't let yourself go into that knock-kneed position. And it's very common. We don't see it. I mean, you see it a little bit in standing, but we see it a lot, especially in women, just sitting with the knees together and the feet outside of the knees. It's okay to sit with your feet together and then bring your knees together. That's completely different. But what we're talking about is don't let yourself catch yourself if you're a person that is sitting with your knees together, but your feet outside of your knees. That is going to put a ton of stress on your knees also on your hips. So what you're doing is you're taking that hip joint and you're just turning it in this way to compress all of that tissue. So it's a very good, it's a very simple strategy. It's simple, it's not easy, right? And so it's really hard to teach ourselves some of these positions, but especially if you're someone that has been used to leaving your feet out and just letting your knees cave in as you sit, you've got to break that habit. Bring your feet straight ahead and then keep the knees kind of lined up either straight, or what we tell people, if the feet are here, you want your knees towards the outer third of the feet, because that's what's going to get the hip joints in the best position. You're going to notice cumulatively much easier time getting up from standing, and you're not going to have as much of that cumulative stress on either the front or the back, especially the front of the hip. But not that a girl, Jackie just nailed it. She just switched
How
how
did you fix
she
it,
was sitting.
Jackie? How did you fix it? Where did you put the pillow?
Oh, I thought she was sitting with knock-kneed.
Oh, either or, yeah, I wanna know what she fixed because we sort of
Hmm.
went over or all 3.
So the hardest part is catching yourself, and it's impossible. It's impractical. If you've watched some of the previous episodes, we've talked a lot about habits, how to build habits. Don't beat yourself up. If you catch yourself sitting like that, it's not the end of the world. It's okay. Correct it. Just oh, I caught it. I'm going to correct it. The more you bring it to the forefront of your brain, the more you start thinking about it, the more you will start to notice it. Just correct it each time. The goal is not to sit perfectly like a statue and a robot 100% of the day. It's impractical to do that. But if you catch yourself, start to kind of just take note of it, fix it, and then over time, you're going to notice less and less. You're not going to be able, or you're not going to be catching yourself as much. And then all of a sudden, usually the tissues won't be becoming irritated as much. And you yourself, by doing that, by checking it and by correcting it, you're starting to build a new software program so that that muscle memory is establishing a new normal, and you're not kind of caving and letting your body think that's okay.
So I want to take Jackie, and maybe then you can sort of look to the what else you want to go over. Jackie's question, which this we get this question 90, I don't know, 95% of our patients when we see them, they ask about the heat or ice question. So I just threw it out there. What's your go-to, ice or heat? Something, typically we all follow a similar sort of procedure unless someone's in very very acute pain where their irritability is really high, like above 8 out of 10. We're typically a heat before, ice after sort of mindset. And what we do for that, the reason behind it, and certain diagnoses are a little different. Obviously, if you had a fresh strain where a muscle was overstretched and then sort of coiled back together and is really tight with increased tone, sometimes heat on that body part will help to relax the tissues before some sort of activity. But that's a key word there. It's before the activity. Several folks that I hear, a lot of them say, I put heat on before bed. Most people do not do much activity when they're sleeping. So it might feel good to have the hot pack or the heated blanket on that body part. But what the heat mechanics actually do to the tissue is it increases the extensibility. So when you warm up a tissue temperature, that's going to actually allow it to be more mobile or stretch better or perform through that manual technique that we're about to do. So typically, if you're going to do heat, it's better to do heat before your home exercises, before your activity, before you're going to do some self releases, or you're going to, at physical therapy, sometimes we'll do heat before we start doing our soft tissue work. That's going to allow that tissue to become more extensible. Ice is I am the ice queen, self proclaimed. I think ice sort of, Joe, did you not know that?
Yeah, I'm learning something new. Yeah, this is good. Yeah.
Yeah. So it's one of the most natural. It's free. It is not a medication, and it can be used and applied on any of your body parts so that are typically experiencing pain. There is a threshold there. Inflammation is a heat-based source, so when you have heat and ice, that ice can sort of neutralize that tissue that is feeling inflamed. So for me, typically, and Joe, I mean, add into this, but you can heat before you do your exercises or before you do your foam rolling or before you do your tennis ball manual therapy or sort of tissue work. But I would definitely recommend icing to reduce the inflammation in that structure that's feeling it. I am common to say bring ice to bed, let it fall off, as long as it's not like in a Ziploc bag, because then it falls off in your bed and that nobody wants that. But if it's an ice pack, bring it in. And once it gets sort of room temperature, it'll probably fall off anyway.
Yeah, and I think, each person, I think those are great general recommendations. And I think, most of the time, people are more comfortable heating than icing, and people tend to shy away from the ice. And so I think that's a great reminder that ice is a great analgesic. It's a great way to calm that pain down. And it's a great way it can help to relax muscles. A lot of people don't realize, because we feel like we tighten up to the ice. But yeah, it's a really nice strategy that I think probably gets underutilized. The heat can be good too. You kind of have to take that inventory and look at a big picture. Don't just look at the short term. So heat will feel good, when it's initially on most of the time. But see how long that lasts for, and play around with it, and kind of open that circle of influence that you have, and see, how do I feel over the next 5 hours? How do I feel over the next 6? And compare when I ice versus I heat, and see if one is giving you different, longer lasting results.
I know Beth had mentioned she's getting some shoulder and upper back pain, and possibly the heat would be a great place to put it there, but then do something. And that could be something that we can sort of go over. But I know right after you sort of warm it up, don't just sit idle. After 10 to 15 minutes of, where did that go? Sorry, my phone just rang. It's my dad. After you do 10 to 15 minutes of that heat, go through some neck stretches that either your physical therapist or that you have been taught, or some postural strengthening exercises, because your tissue is now ready for that.
So I want to jump down to the super simple formula, the super simple secret formula for injury prevention. And so hopefully we'll be able to see this. So I'm going to share the screen again.
Oh, good thing. I almost kicked that off. Yep, here we come. Sorry.
Oh, that's good. So what happens is that good, or do you want me to? Yeah, we're not gonna be able to see that well. So the joint by joint approach was made popular by so Mike Boyle gets credit, Gray Cook, Charlie Weingroff. So it's essentially it's almost like a systematic way that our parts of our body either need mobility, so movement, flexibility, if you will, or they need stability, so they should be more stable. So they should either be moving or they should be stable. It's important to take the concept with kind of adjust, like with a grain of salt. So all of our segments should be able to move for the most part, and all of our segments should be able to stabilize. So these are general principles and almost a formula that we can use. And so when you're looking at the neck, you really need the neck to be stable. So what happens a lot of time is people actually try to move too much from their neck. And those are the people that you see always cranking to try to crack your neck. You're always stretching your neck out. Um, Similar to what Sue said, I know she was speaking about her lower back, but it's always feeling tight. And so I always have to stretch it out. In the neck, we should have stability. In the thoracic spine, the mid back, we should have mobility. In the lower back, we should have stability. And how many people feel like they constantly have to stretch out their tight lower back? Really, we should be stabilizing our back. Our hips, the ball and socket joints that we just got done talking a lot about, they should be mobile and moving. The knee should have stability, not allowing it to go into that knock knee position. And the ankles should be mobile. What happens, the compensation pattern is almost the inverse. So from what we just described should happen, we end up doing the opposite. So our neck, we constantly are trying to stretch it out and get it more mobile because it feels tight. If we go down, it's usually because the thoracic spine is too stiff. The thoracic spine are the middle 12 vertebrae in our mid back, and they have ribs that come off of them. There's a lot going on in that middle region. And so it should be mobile, but it tends to get very stiff. We're all hunched over our computers nowadays, and that tends to stiffen us down. If we don't have the mobility in our mid back, in our thoracic spine, it's going to ask the neck to try to do its work. It's just like the example I gave with Aaron and I. If I show up to work and I go in the back room and take a nap, Aaron's going to have to do double duty. That's what the neck tries to do. The neck tries to make up for the lack of mobility in the thoracic spine. And that's why it gets really stiff. That's why we feel like we always have to stretch it. The same thing with the lumbar spine. If we're lacking motion and mobility in our thoracic spine, the lumbar spine is going to be asked to do more. Hey, just help me out. A little bit more motion. And then those muscles are going to tighten up. The lower back is going to feel more stiff, and we feel like we have to stretch it. Same thing with the hips. Hips start to tighten up if we're not using the hip ball and socket joint. If we're not getting all of that mobility there, we're going to ask the lower back to do more. We're going to ask the knees to cave in. And so it's almost an inverse pattern going back and forth. And that is super important to realize, because we really need to start to impart some of these injury prevention strategies based off of this. How do I stabilize my neck? How do I loosen up my thoracic spine? How do I stabilize my lower back? How do I loosen up my hips? How do I stabilize my knees? How do I loosen up my ankles? The seemingly simple strategies that we just talked about with sitting and not letting yourself sit with your knees caved in, that right there is a strategy that is going to help to stabilize your knee. If you allow yourself to sit with your knees in that knock-knee position, you're adding excessive mobility to the knees that they don't need. And you're actually, kind of setting yourself up, uh, not for failure necessarily, but not as efficiently as you could. You can pop back off or back on air. So that strategy, that concept of joint by joint, and we can probably I don't know, maybe we can link into that in the comments or something. That is super important. And really what you would want to do, the best way to go about that is try to incorporate mobility strategies for the thoracic spine and the hips and the ankles. If you can start to do that, all of a sudden the other spots, the common areas that we see people, man, my knees are killing me. Man, my back's killing me. Man, my neck's killing me. If you go for the spots that should be more mobile, that automatically is going to take some stress off of those other areas. Now, you talk about the people that had hip questions and hip pain, right? So the one person, sorry, I forgot the name, that had back of the
Carla.
Carla. So Carla had back of the hip pain. We talked about sometimes that actually comes from the lower back. I would not be surprised if Carla, if her hip isn't moving maybe as efficiently as it could, putting some of that stress on her lower back. And if she could loosen that hip up a little bit, that back of the hip pain might resolve. Similarly, front of the hip pain, right? With Linda, if Linda, maybe we check her out. Maybe there's not as much stability at her core in her lower back. Maybe your core is very strong, Linda. I'm not sure. I'm just going off of generalizations. Yeah. But clinically, what we would look at, and it would be very common to see, some areas where we could start to strengthen the core. All of a sudden, those hip flexors don't have to work as hard. The pelvis doesn't compensate as much, and then that front of the hip tissue doesn't get irritated, and now that front of the hip pain starts to resolve. That's one strategy. The other strategy that's really great is the gaslight, and I love the gaslight. You would not get in your car and go for a drive from Albany to Buffalo if you weren't looking, you check your gas light first. If your gas light's on, you do not need a new car. You do not need a mechanic. You should probably at some point stop and fill up with gas. In life, if you go back to physical education class, and it might be different now, what we're told is exercise falls into like one of three categories. It stretches, it strengthens, or it does my cardiovascular. And if I'm going to go work out, what I have to do is I have to warm up first. So how am I going to warm up? Well, I'm going to do cardiovascular, right? I'm going to get my heart pumping. I'm going to get my blood pumping. We need to incorporate movement warm-ups. We need to warm up our movement system, because we talked for an hour and 12 minutes right now about how the brain controls this, and how a lot of us, especially during this time period, are crunched in front of computers. So that throws our movement pattern off. That throws our software system off. So our warm-up should be incorporating software resets. So we should be improving our movement coordination using that joint by joint approach, and getting some thoracic mobility exercises in, getting some hip mobility, some ankle mobility, some core strengthening. And this doesn't have to be, an hour of corrective exercises, but we should have a couple things. And if you've had the opportunity to work with a physical therapist or another type of healthcare provider, what we say, the goal at the end of this, the end of a PT plan of care, Aaron, I want to get you 2 exercises that you can do that's going to set yourself up, right? I want to get you one thing. You're going to go to the gym. I want you to check this. If it's good, great. If you've got time, do your corrective still. If you don't, that's okay. You're going to go in. There's no such thing as a fix. We're not going to fix you, right? But we're going to empower you to do this. So you're going to go in, you're going to check your gas light. If it's your toe touch and you go in and you can't touch your toes, you should not work out. You're trying to drive to Buffalo on an empty tank of gas. The car will break down on the side of the road, and someone's going to have to come and put gas in your tank, right? So if you go in and you can't touch your toes, just like we did in the clinic, here's a couple resets. You do your things. If you can then touch your toes, go work out. But we get in our head like, I just have to get through. I just have to get through. And what that does a lot of times is it cranks the radio up, right? We drown out some of those compensations and we go from there. So it's a way to really empower people to take care of themselves, right? And learn some of these strategies. So what's your gaslight? Use the joint by joint approach, right? To find out where these common areas are. So if you're constantly trying to stretch your neck out, if you're constantly trying to stretch your lower back out, there's probably some things we can do and incorporate in the thoracic spine and the hips to stretch things out and go from there. And the little strategies like we talked about of sitting and changing how you sit, that is a way to leverage those software resets throughout your day. Proprioception, it's that position sense, and you're going to cumulatively take stress off of those tissues. You're going to remind your body of where those neutral positions are, and it's going to make a world of difference cumulatively over the long term. It's tiny things, but over the course of the day, over the course of the week, 1% better, and then it adds up to big changes.
So, Joe, what is if we were going to wrap it up, if you will? I know I went back. We have one more question that I definitely want to get to. But what is the single most important thing that we probably should do about the pain we are experiencing?
So, and I think we've touched on it, right? So there's a couple different avenues you can take. So we all experience pain, right? At one point or another. You have a couple options, right? You can ignore the pain and we just go through it. Probably the least effective option. You can alter the pain. Remember the story of the car. You can crank the radio up and you can drown it out. There are strategies that we can use throughout the day with over-the-counter medications, just avoiding activities, those types of things. So you can alter the pain, or you can kind of identify what's going on and you can put a plan in place to address it. So, those are really the three avenues. And I think the big take home is pain is your body communicating with you, and it's not its job to identify tissue damage. It's its job to tell you you need to take action. So there's something that needs to be addressed and go from there. So, I think that those would be the biggest take homes, I would say, is, use that same approach, expand that circle of influence, try to objectify when you get the pain. Where is it? What is there a pattern? Every time I do this, the pain comes on. Every time I, you know, this workout previously wasn't bothersome. Now it's bothersome. All right, what did you do before the workout that was different today? Oh yeah, I took that car trip to Syracuse and back. And that, okay, so maybe we need to talk about how you're sitting. And so really, take the time to objectify it, figure out what the variables are, and we can change those variables. But there are a lot of seemingly simple strategies that can be incorporated. And if you have any questions at all, please do not hesitate to reach out, and we can go through this same type of scenario, and even obviously in a lot more depth, because we can see where your individual compensations are, and put a plan in place for you, so you know exactly what's your gaslight indicator. Where's your compensation? Is it your thoracic spine that's not mobile? Do you need stability in your lumbar spine, in your lower back? And what are the most efficient things that you can be doing so you can get back to moving well, living life, doing what you want to be able to do?
That's awesome. Thank you so much. And if we do want to get to, if you have any questions, stay on. We said that we wanted to sort of add this element so that we can answer. Hopefully, we've gotten to a few personal questions. But as Joe mentioned, if you email him, he'll get back to you. He can start a conversation about actually what might be more applicable to you specifically. Sometimes on a forum like this, it's hard to have the time to break down everything. Little tips can be helpful for sure. Beth's question is that she is feeling more upper back or upper shoulder and back pain from more sitting recently, and sort of what strategies or exercises can she do to reduce that. She also uses heat more than ice, she mentioned in some of the comments. And Beth, if you want to add anything else in about some of the pain, feel free.
So what we know about upper back and kind of shoulder region pain. So if it's kind of right through that trap area, Beth, and kind of extending down towards the shoulder blades, there's a lot of muscular attachments there. If you look back or think back to that joint by joint approach that we talked about, the thoracic spine is very crucial because all of the ribs, so that mid back area is very crucial because all the ribs come off of the thoracic spine. Those ribs serve as the foundation for the shoulder blades. So if there's any compensations through there, if you're not moving well through your mid back, now the shoulder blades are placed in an inefficient or less efficient position. If they're in a less efficient position, the muscles that attach from the shoulder blades out into the shoulder, out up into the neck, those are in a less efficient position, and it creates this cycle. So typically our approach is to see where the movement is limited in your mid back and give you strategies from there. A common one would be if you're okay in like a yoga position, cat camel can be a really good way where you're on your hands and your knees and you kind of curl your spine up this way and then you sink it down that way. That can be a really easy one to start to identify some and start to work on some limitations in your thoracic spine. The other one is, we've been talking a lot about our posture and being over our devices, especially at this time if we're working from home. And what happens is, if that thoracic spine loosens up, things are in front of us, our shoulder blades start to come forward. If we tighten down in the front, that ends up putting more stress in the muscles in the back. So we feel it in the back, but we're actually less efficient because the muscles in the front are really tight and we actually have to kind of loosen ourselves up and get back there. So something as easy as kind of squeezing your shoulder blades back. If you have a foam roller, doing some gentle pec stretches over the foam roller where the foam roller is laying down on the ground and you're kind of laying over it that way. Maybe, yeah, I'm sure we can probably link to that, Beth, or shoot you over some videos of those.
I just put the cat camel YouTube in the comments. Also, this is an apple, but it sort of looks like a tennis ball. And so this is something where you can sort of put a tennis ball right into the front of that pectoralis muscle group up closer to where it sort of inserts into the front of the shoulder. And you can either just rub around with it, or you can lean up against the wall where this tennis ball or apple, hey, apple actually works pretty good. And so I can do some soft tissue sort of releases to that pec tissue.
Just make sure that apple doesn't make it in my lunch tomorrow, please.
I was gonna say, I should definitely just eat this tonight.
So what happens is that the tissues so it's really important to have these conversations because a lot of people feel it back here. We talked about how muscles of opposite actions can kind of play in. So we feel it back here, but that might not be the tissue that is getting, or that is really the culprit. And so all of that tissue in the front acts as kind of like the parking brake. If you've ever tried to drive your car with the parking brake on, you can hit the gas and it'll go, but it's not as efficient. You take the parking brake off and then you really take off. The pecs a lot of times get really stiff, really restricted, and those act as the parking brakes for the muscles of the back. And so if you take that time with an apple or something else and you loosen up the pec tissue, then that can take almost immediate stress sometimes off of the muscles of the upper back.
So Elena's loving your acronyms and all of your
I've got more of them. I don't want to keep, yeah.
it makes me laugh. All right. Anybody else? We'll just stay on for another minute or two if you have anything else specific that you want to go over. One thing I was thinking about is even right now, any of those of you who started tuning into us and now we've been going for 80 minutes, what position are you in right now? Are you in your bed and you have your phone sort of down here? Are you sitting up against the couch with a pillow under your hip, your knees perfectly straight, not diving in with your feet flat on the ground? Are you laying on your side? Well, in some of these positions that we commonly get in for shows, for Netflix, these are positions that you do for a long period of time that can be putting more stress on your body. So we talk about position sense all the time. All right, Jackie, I am wondering about sleeping. Do you have a recommendation for pillows or mattress firmness to avoid pain from sleep? Jackie, where is the pain in your sleep when you're sleeping? Is it more in your neck, upper back? Is it low back? We have a really cool tip that maybe, Joe, if you want to go grab one of the pillows that are right near where you are, one really great neck, and this could be helpful for Beth as well, for the position with the pillow. We typically say one medium-sized pillow is perfect. Anything more than that might throw yourself into too much cervical flexion when you are sleeping. So one medium-sized pillow should keep you in a pretty good neutral position with your neck. Joe's going to show you a towel roll that we recommend highly to put in the bottom base of the pillowcase. That is helpful for that upper trap, neck discomfort, sometimes like that left arm that might go numb. We hear a lot of that. So that's at least for the neck. Joe, do you have it?
Yeah. So if you're a side sleeper or you're a back sleeper, stomach sleeper, probably the recommendation is don't do that. um, there's strategies, but so imagine I'm on my side right now. If you look at the anatomy of my neck, there's a curve here. There's a natural curve, and obviously the shoulders are much wider than the neck. And so as the pillow comes down, what happens when people, yeah, this whole mirror thing.
I
What
know, right?
happens is there's dead space still here, right, in the pillow, and you're not fully accommodating that curve. And so what you can do, you have a couple options. The first one is take the edges of the pillow and pull them down around, right? And that fills up the space. What we commonly see is people take their arm and wrap it up under the pillow. If you put it up under your pillow, that's your brain, or that's your body seeking stability. You're trying to fill that dead space up. So instead of that, just I'll race you. So take a towel roll and then, take that towel roll and slide it in your pillowcase horizontally. And so what you're going to do when it's in there horizontally is you've kind of created almost, I don't know if you'll see it well. Yeah. So
This is
it
down.
basically
Yes.
fills up that dead space there. And so your arm doesn't have to go under as much. You can kind of tuck your arm across your body. But that towel roll, whether you're a side sleeper, and then a lot of people, the common complaint is, well, I don't stay in one position when I sleep. Because the towel roll is in the pillowcase, you start on your side and then you roll onto your back. It's the same thing. There's a curve in your neck when you're on your back. Because that towel roll is there, You don't have to, in the middle of the night, readjust your pillow. You don't have to put an arm there. The towel roll does the work, and it should help to support the neck a little bit more. So that's probably the best recommendation. Once I have this conversation with people, they say, well, should I just get one of those curved pillows? The trouble with them is everybody's different. My neck curve is different than Aaron's. And so, you're kind of at the mercy of however that manufacturer made it. It could work. It could work great. It might not work. So you do the towel roll. You can add layers.
I was
You
gonna
can
say
make
you
it
can
thicker.
change the diameter of the roll, and that's where the pillow. So you might want to start with something smaller. Maybe it's not built up enough, so maybe then you do two of these towels. So and then everybody has a different amount of curvature there. And
Yep.
then
And then
just, you said sometimes your low back as well. It's not new news, but it's still common putting a pillow between your knees. It's that same philosophy of when you're sitting and your knees are diving in, and that the position and the stress that that puts on your pelvis and your low back. Similarly, when you're on your side and you have gravity and the weight of that top leg on the other one, that's just going to force yourself into that anteriorly rotated position. So putting a nice, and I always go for a long pillow, one that can almost span your knees all the way down to your ankles. So not just your knees are apart, but your ankles also have that space in between as well. And so that's sort of what we recommend for side sleeping with potentially that low back pain. It's just one tip. Firmness of mattress. Joe and I took we do a lot of research. Joe's a big researcher, and we just got a new mattress, and so he can sort of go over quickly what that showed. But there's a lot of different information out there about firmness.
before we do that, there's one more with the pillow. So same thing when you're on your side, the pelvis is wider than the hips and even wider than the spine. And so there can be a lot of pressure on the pelvis there. And then that creates torsion one way or the other. So certainly the pillow between the knees can make a big difference. Like Aaron said, some people actually do well if you take a thin pillow or whatever, mess around with it and see whatever thickness you need. Take that pillow, Jackie, and you can put it up above your hip area. Let me see. So it would be like this region right here. The pillow lays right there when you're on your side, right up over your waistline. And what that does, because the pelvis is a little wider and then it dips in, it fills up that dead space between the bed and the mattress in that area. And that can do a great job of decompressing the lower back, both the joints and the musculature there. So pillow between the knees. And you can also, if you need, put another pillow up above the hip and the pelvis. Mattresses come in a bunch of different ways. So they objectify it. Lucy actually did a journal club article on this. And so I think, it's tough to give generic recommendations based off of it. So, you want to, they do a very good job actually if you get on the manufacturer's website or Consumer Reports, if you're a Consumer Reports person, they do a good job too. It was like a 0 to 10 scale, and it's super firm, super soft, or it's somewhere in the middle. It's going to depend on body type. So it's going to depend on how tall you are, how much you weigh, what position you prefer to sleep in. So I think, Jackie, you said you're a side sleeper. Side sleepers like a little bit of a softer mattress, kind of medium to a little bit softer, because our bony prominences, I'm a side sleeper as well, our bony prominences are more exposed when we're on our side. If you're on your back, you can get away usually with a little bit firmer mattress because those bony prominences aren't as prominent, aren't right down into the surface. So yeah, it's tough to make generic recommendations. There are a lot of factors, and they actually do a good job. I don't have the resources right in front of me, but I can certainly kind of pull out my mattress spreadsheets and and get that information over to you, Jackie. Usually, if you're a side sleeper, though, you're gonna want probably not too firm of a mattress, just because your shoulder, you're right on it, your hip, you're right on it, and your bony prominences are just a little bit more exposed.
Awesome. All right, Joel, I don't think there are any more questions. We gave out some great, awesome content tonight. Thank you guys so much for those of you who shared this stream or this video. We really appreciate it. I'm able to look to see all that, and one of you we will be giving you this new copy of the book about pain, Painful Yarns. So thank you again for doing this. If you liked this episode, feel free to give us a like or a love. Will have allow more people to see it, especially if they're having any pain. We're happy to help them as well. But yeah, that's all from us today. We have really exciting guests next week. We are going to be having Eileen and Pat, the owners of Anatomy, are going to be coming on and talking about everything in the fitness world right now and what they're doing to keep people's minds and bodies going despite all the changes. Thank you guys so much for this. We'll be leaking out some of the topics we are going to be talking about next week. If you have any fitness questions about how to start implementing your fitness goals after an injury or through pain that you have, let us know ahead of time. You know the different ways you can reach us on Facebook or email. But thank you guys so much for attending.
Everybody have a great week. And yeah, any questions either from this episode or anything coming up fitness related, like Aaron said, definitely reach out by email this week.
All right, guys, have a great week. Happy Mother's Day to all you mothers out there. We can't wait to see you next week.
Happy
Bye.
Mother's Day. Have a great week.